Good afternoon, everyone. Thank you for joining us today. We will get started here in just a couple of minutes. Looks like I've got a couple of committee members who have put their name in the chat. Thank you for that. As a reminder, if you are a committee member, please put your name in the chat. If you are a committee member who is on the phone, if you would unmute and let us know that you are here. We will get started here in just another minute or two. Thank you. Okay, Rachel, it looks like we've got a quorum, so you can go ahead and get started whenever you are ready. Thank you.
Thank you, Sharon. I appreciate it. Hi, everyone. Welcome to the December MAC meeting. Happy to have you all here. We're going to get started. First, I will take any motion to approve the November minutes.
I'll move to approve the minutes. This is Kim Dancy.
Thanks. Anyone like to second that?
I'll second that, Rachel.
Perfect. I appreciate it. And then we also want to welcome Alicia Beckstead as the new provider rep for local health departments, replacing Gina Tuttle. Alicia, welcome. Would you like to introduce yourself at all to the group? No pressure. We'd like to give everyone the opportunity.
Yes, sure. Hi, I'm Alicia Beckstead. I'm a registered nurse with our local Central Utah Public Health Department. I'm the director of nursing here, and I have been with the health department for about 19 years. And I'm excited to join you guys.
Thanks. We're happy to have you. And a good meeting to start with, in my opinion. So I'll just go ahead and pass it off to Eric Rett, who's going to present the Medicaid associated items inside the governor's budget, which was released earlier this month, I believe.
Yep, that's correct. Thanks, Rachel. This will be a really quick report because there just wasn't a whole lot for Medicaid in the governor's budget this time. So the main item that we always talk about is Medicaid consensus. And for those of you who are newer, I can kind of explain what that process is. It's where the department meets with the legislative fiscal analyst in the governor's office of planning and budget, and we come to a consensus agreement on our projections for Medicaid enrollment for the current year and also the upcoming year. So we kind of come to a consensus agreement on enrollment. Then from there, we adjust it for any new funding or new programs that have been approved by the legislature and establish a per member per month cost, and then multiply those enrollment factors, trying by that per member per month cost to arrive at what we need for funding. We then compare it to the existing funding we have and either make adjustments up or down. So for state fiscal year 2025, which is the current year, our October consensus, we're projecting $83.5 million give back to the state general fund. For state fiscal year 2026, we're projecting a $53.4 million ongoing need, and then also but with a one-time give back of about $30.6 million. So these are just our projections as of October. We do a revision to consensus in February as we have more information at that time. So that's the main piece that was in the governor's budget. Then for new funding items, the governor's budget included funding for HCBS waiver and home health rate increases. Now, despite the name, this is specific to two HCBS waivers, which are the aging waiver and the new choices waiver. So don't let the name fool you. That's actually what the funding is for. The funding is actually for those two waivers specifically. And then the final piece in the governor's budget related to Medicaid was a reduction of $4 million ongoing for Medicaid pharmacy. And this was in relation to a report that was issued to the Social Services Subcommittee about ways that Medicaid could change how we do pharmaceutical products with our managed care plans. We're currently working through that process with our managed care plans. And so this amount in the governor's budget is kind of almost like a placeholder of what that will ultimately end up being. So that is everything that's in the governor's budget for Medicaid. Any questions from anybody on the committee?
I'm going to take that as a no. So thank you, Eric. We appreciate it. Good to see you, even however quick.
Yeah, we like to be quick.
Right.
Thank you, Rachel.
Yeah. And then we're going to move on to, and I forgot how to say that acronym already again, because I was told the other day and have forgotten, but the HEDIS and CAHPS measures. I'm going to pass it off to Greg Trollen to go over this.
Hey, Greg, you're on mute, by the way.
Greg, can you? Oh, okay. We still can't hear you.
No,
We
I can hear
see
you
your
guys.
screen.
Yeah. I typically need a mute refresher from somebody in the audience when I start talking. So, all right, let's see. Okay, do you see a slide that says MAC 2024?
We do.
Okay. Okay, again, welcome everybody. My name's Greg Trollen. I am the Office Director for Managed Healthcare, and joining me this afternoon is Jennifer Meyer-Smart, who's the Assistant Office Director. So we're going to tag team. I know that the agenda says specifically HEDIS and CAPS, but one of the things that we've expanded on is just providing an overview around the quality work that we're doing in the managed care space. This is critical work for us. We've done a lot of things in a fairly short amount of time, and we want to highlight some of that through our overview. Specifically, just looking at how what we're doing maps to our division vision, and then walking through several of the quality activities and initiatives that we are both in the process of engaging in, implementing, as well as planning for. Okay, so looking at our integrated healthcare vision for our division, right? One of our key elements here is just to promote the health of Utahns through innovative, cost-effective strategies. And in this second bullet, we've underlined some of the key elements that are part of this vision. And these underlined areas here, which include member experience, preventative services, integrated models and integrated care, and then also moving from a fee-for-service environment to more of a value-based reimbursement methodology for how we reimburse for care and services and quality. These things map directly to our commitments that we made to the One Utah Health Collaborative. And so these were things that we identified. Some of this also was represented in some of the previous budget documents that the governor's office had put out. And so as we go through these things, we keep in the forefront of our minds how these things represent and map back to our overall vision and strategy. So one of the things that we recently did was, so we used to just have sort of a one-person quality shop, and that person was responsible for managing our external quality review contract that we have with our external quality review organization, as well as just mapping out specific requirements, of which there's a lot related to managed care, and specifically around quality and quality performance. So one of the things that we've been able to do in the past few years is actually grow our quality team that we have in managed care. So we went from one person to now having 4 individuals. In conjunction with that, we also knew that as part of that growth, we needed to bring in some expertise that would help us shape both the direction of quality that we have in managed care, but also to just grow staff knowledge internally. And so one of the things we did was hire a quality contractor who's been really helpful with us, both from an educational standpoint, but also to help shape and inform the quality initiatives that we've started engaging in. And that quality contractor is HMA, which is Health Management Associates. And then the second contract that we implemented was for our population health management system. And the primary, or I should say the initial work for this contractor, and the contractor's name is On Point. The primary focus that we've had since that contract started late in the spring has been on the core set reporting requirements that states are obligated to send in by the end of this month. And so their primary focus has been on development of the mechanisms to get the reporting done, get them, and then get us to a point where we can actually submit the requirements for that reporting. But the nice thing about the population health management system is it's just not designed to be a reporting fulfillment process, but really to look at population health and to take the data that we get related to our membership and be able to use that information to ask questions and to find areas where we can improve the either access issues or looking at ways to reduce health disparities, to close access to care gaps, improve quality. So that's the exciting part about the health management. We do have requirements on core set reporting, which are due at the end of this month. However, we're really excited about the work that's going to occur on the population health side. One of the projects that we're working on is finalizing our managed care quality strategy. So our managed care quality strategy is a document that's renewed every 3 years. It's a document that we submit to CMS, but we also make it publicly available on our website. And this quality strategy is really supposed to be a comprehensive overview about what we're intending to do over the course of the next 3 years. And we've really done a rework of this document. If you go to our website, or if you just Google Utah Medicaid Managed Care, it'll take you to our managed care webpage. And if you go down to resources, you'll be able to see there's a link for our current quality strategy. So our new quality strategy is going to be similar in ways, but it's really designed to pull in both what we're intending to do, what our division vision is, how we map quality with other state activities, and also how do we map to really the national landscape, particularly around quality framework and health equity. And so you'll note that here, although we noted that we will release this for public comment, we'll be sending this out for feedback. Although we say January 3rd, I know over the next couple of weeks, we have several staff who are going to be out. So I don't know if the 3rd is reasonable, but I know in January we'll be making it available for people to comment on. And then we'll have a 30-day comment period and then take that feedback, review that, incorporate it, and then finalize our quality strategy, and then get that sent off to CMS. So moving on to another quality initiative that we did in our SFY 2024 contracts, which would have come to a close June 30th of this year. We had a quality incentive pool for our ACO contracts. And this was specifically on the physical health contracts that we have with the ACOs. And here what we did is we had a pool of funding that we made available to the ACOs that they could essentially earn extra dollars in reimbursement for specific measures that we had identified and for their performance on those measures. And so this really was one of our first forays into really reimbursing for quality activities, where we had specific dollars that were tied to performance. And in this particular project, what we had in those contracts for last year was specific areas, again, member engagement, which is one of our key focus areas for the division. We had a focus on HEDIS measures, specifically well child visits and childhood immunizations. We also had a measure around health plan accreditation. So we have 2 plans who are NCQA accredited health plans, and then we have 2 other plans who are working towards health plan accreditation. And then we also had a measure around data timeliness and accuracy. Now, what we did with the 2025 contracts is we moved into a quality withhold. So in 2024, we had some additional funding, and I don't want to get too complicated here. We had some additional funding that we couldn't build into the rates because our rates have to meet an actuarial certification. And so that actuarial certification requires that rates comport with several different factors, and you can't have rates that are too high, because they potentially are not actuarially certifiable, and also too low. So we had an extra funding pool that allowed us to start that initiative in 24. In 25, which is the current fiscal year we're in now, we've added a quality-based withhold for capitations to the ACO contracts that are being paid out specifically, again, on the measures that we had started with last fiscal year, which are well child visits and childhood immunizations. And then, let's see, is there a question?
Hi, Greg. It's Stephanie.
Hi,
Can I ask
Stephanie.
a quick question? This
Yes.
is really helpful. I just want to make sure before you go on, if I understand. So is the 2% withhold, so there used to be, and I'm just trying to understand if this still does exist, there was like an annual increase to the plans, like in their monthly capitated amount, right? I think it was like 2% or something. It was a part of, like, I think the legislature passed it, but it was like a part of the consensus or whatever they call it. And then is this an additional amount that's contingent upon other things, or is like the increase, like is all increases contingent upon certain things, or is it like they have an increase annually and then an additional increase is contingent? Does that make sense?
Yeah. So the 2% that the legislature, or that's built into statute, so that gets rolled into the budget pool. And then as Eric was just mentioning, sort of there's this consensus process, and then there's, conversations about projected enrollment, and then how much funding there is. And then they develop this budget pool. So then the budget pool is then used to set rates. And so last year, what we had is we had a budget pool that had additional dollars in it that couldn't be built into the rate. So we made that money available and paid that out based on performance on quality measures. The withhold, what we've done is once we set those capitation rates, we're essentially paying the ACOs. So we have a capitation rate, and then we take 2% of that rate and we withhold it. So it's basically sitting on the side. And once we have the information related to the measures, then we'll see where the performance is and pay out that up to 2% of that withhold back to each of the plans based on their performance. Did that answer your question, or is that?
Yeah, no, that was really helpful. Thank you. So then, that if you were to like just put a graph, like imagine a graph in your head of like the capitated, like just like the rate set every year. I mean, they do go up, right? And I'm not saying they should or shouldn't, but they do go up. And so this 2% withhold is like separate from that.
Yes, that's correct.
Okay. Okay, great. Okay, that's what I wanted to
All right,
understand. Thank you so
sorry.
much. That was really no, that was really your answer was very helpful. So thank you. Sorry, continue.
Sure. And then to the second bullet here, now we're also planning for a similar 2% withhold on the UMIC plans, which are Utah Medicaid Integrated Care Plans. And we're looking at that for SFY 2026. And again, this is under discussion. One of the unique things about the UMIC plans, for those of you that don't know, it's specifically the expansion population that are enrolled with the UMIC plans. They're in our 5 most urban counties. And they are right now just in 5 counties. And then the other thing is the integrated plans pull both physical and behavioral health under one managed care plan. In this case, it's the ACOs who both run the physical health plans, but they also run the UMIC plans. And so we're looking at a 2% withhold with an application for SFY 26, but we're also sort of focused on determining what those measures should be and how we go about implementing that. Another.
Hey, Greg, real quick, if I could interrupt. Dr. Brenton has her hand raised.
Who does?
Dr.
Oh,
Brenton.
sorry. Yeah. If someone could just monitor that, because I have like 3 screens going.
Sorry,
I won't be able to see.
No problem. Hey, on those HEDIS measures for immunizations, I know some insurances, because as you know, some families hear a lot of misinformation from lots of public leaders and won't immunize. They give us credit if we've counseled and gotten a refusal from families. Will that be accounted for, or will we still be required to show we got immunizations given? Even will it be a ding on us as a physician when the family has unfortunately, been a victim of misinformation that we can't overcome? Or will we get credit for saying, look, we counseled, they refused, that's in the record now, so that counts toward our benefit there?
It's a good question. I don't know the answer to that because I'm not totally familiar with the specs related to the HEDIS measures and all the criteria that would go into whether it would count as a valid, like, representation or a valid sample, but we could get back to you and
Greg, Rachel has her hand up. She can
Sorry.
clarify that.
This is Rachel from Health Choice. I'm the quality manager. Yeah, I can help out with that. So unfortunately, the HEDIS criteria does not allow us to record refusals as compliance. So the payers would actually get dinged in their rates when it comes to that.
So just my concern is that physicians who agree to have, one thing we're counseled in our pediatric practices and family medicine practices is not to decline families who don't immunize because we want to still be a resource for them and continue that conversation. But this would actually penalize physicians who have kept those patients in their practice. We wouldn't get that 2% part of that 2% back. And so it's actually a physician penalty done this way. I'd recommend that somebody work out, since this is not a law of gravity we can't change, that somebody look and see who could change that to make sure it's not a penalty on physicians. I wouldn't want there to be any economic reason for us to refuse families that really need our care, need our advice. Thanks.
I'll just add, I think I think your point's a good one, but there is a difference between the health plan reporting and then what the health plan does with the providers, right? So the contracts that the health plan may have with you, Dr. Brenton, or other provider groups could be measured differently than how the state has to measure their HEDIS. Does that make sense? So I'm not sure. We don't look specifically at how the health plan creates its incentives for you as a provider in the measures. But with regard to health plan reporting up to the state, I think that's differently, but the health plan could, in their arrangements with you, it doesn't mean they're passing that 2% directly to you. This is how Medicaid is measuring the health plan compliance, not necessarily dictating how the health plan creates its contracts with the providers themselves, if that makes sense.
It still just seems whoever's doing it, somebody's going to get a ding when we are.
Yeah, I understand that. And like Greg said, we can take that back and consider how that data could be brought into the way that the specs are calculated. But yeah, Emma has a comment on it, but yeah, just with regard to how that 2% could directly affect you. I don't know that the 2% is with the health plan, not directly with how you get reimbursed from the health plan. I think I just wanted to make that, just create that differentiation. I know it gets complicated.
And Jen, I was just going to add to that you are correct. And I think, I don't know what all the health plans are doing. I can only say that, what we've tried to do is incentivize providers, not penalize providers for, encouraging families to get their children immunized. But what Greg is talking about now is just between the state and the plans, not between the plans and the providers. So I don't see the providers as being at risk based on this discussion at all. And I will also say the criteria for these measures are established by NCQA. So
Right.
it will take working with them to change any of the criteria for these measures.
Yes, but thank you for the question and the comments. Okay, so another quality area that we're stepping into is what called quality-based auto assignment. And this is specifically related to how individuals who are new to Medicaid become enrolled with a health plan. And if you look at how individuals coming on to Medicaid, they have an opportunity to select a health plan. They receive materials if they're in a particular geographic area that will be tailored to them depending on their residence. And it'll indicate that they need to reach out to us and select a health plan depending on what those criteria are. And typically what we found is we have approximately 30% of individuals who actually don't pick a health plan initially. And so we have an auto assignment process that essentially looks at round robin assignment of individuals into each one of our health plans, depending on whether that's ACO, dental. And so what we're proposing to do here is look at a series of quality indicators and evaluate those indicators and assign auto enrollment based on quality. There's, what should I say? It's relative. So we're still in the process of deciding what those quality indicators should be and the methodology by which we would go about using those indicators or the performance on those indicators. But it's one of the things that we're proposing to look at implementing in 2026. I heard a few bings. I don't know if those are hands or questions. Or maybe
No one
that's
has their
just
hand up right now.
Okay.
So
maybe someone's just
Let you
reaching
know.
out to me.
I'm
It's
monitoring
probably okay. Another quality project that we have in our shop is the hospital quality project. Now, this was shaped by SB 126, which made some changes to our directed payment processes. And directed payments are intended to support increased quality and access to Medicaid services for Medicaid members. And directed payments essentially support hospitals in this case, and the services that they're rendering to ensure that members have access to care and to hospital services that they may need. So what we've, in this particular project, as with SB 126, it required that we establish a hospital quality program that would essentially tie hospital quality measures and performance on those measures to the state directed payment dollars that are being paid out to the hospitals, and specifically to the specific directed payment dollars that are included or represented in the subsequent, legislation, or I should say the statute that was formed as a result of SB 126. So based on our program, hospitals are at risk for up to 3% of their state directed payment dollars for the state fiscal year based on performance on quality measures. And we're currently finalizing the evaluation methodology for the quality measures for the hospitals receiving directed payments for SFY 2025. Another item that we initiated, and this has been probably about 2.5 years now that we got this project started, and this was a collective performance improvement project that all the ACOs have been participating in. And it was essentially to create a well child visit card that were distributed to various providers, as well as various distribution methods for members and enrollees. And it was essentially to, again, drive out improvements for well child visits. And in this case, the development of a card, a distribution of that. The main goal here was to create something tangible that individuals could keep, but also could track checkups that their kids had during the course of the early, up to 30 months. I mentioned earlier that with our population health management contractor that we're obligated and will be reporting out on core set quality measures that are for both Medicaid and CHIP. And the adult core set really is a key focus for us. It looks at various domains for assessment. And when we're looking at what we're intending or what the requirements are for this initial submission, we're going to be submitting the child core set along with the adult core set specifically for behavioral health. The other thing that you'll see in the near future is once we do this reporting, we also will be just putting out, making this public facing. So for these core set measures, there will be information available on our website that'll show how we're doing on these particular measures. And this then leads into our emphasis. Again, we noted the mandatory core set reporting, as I was just mentioning, but this also then is going to inform some new quality rating reporting that all states are going to have to engage in. And specifically, it's called the MCAC. So it's Medicaid and CHIP Quality Rating System. And our timeline, even though the proposed rule and the final rule came out in late spring of this year, the MCAC is something that has to be developed and built. But what it's designed to do is provide outward-facing information that individuals can use to assess how providers or health plans are doing with respect to these particular core set measures that are identified for the quality rating system, and then providing them with information that allows them to better select healthcare. Okay, so I am now going to turn it over to Jennifer Meyer-Smart for a quick kind of overview of HEDIS and CAPS.
Okay, hello everyone. Before I start, I just want to mention that we plan to send an updated version of the quality report that was sent out earlier by Sharon, because we found that we need to update some information for earlier years. Specifically updating the sample size information when the sample size is too small for HEDIS. And then for CAPS, we're updating when not enough responses have been provided. So we'll be sending that updated report out as soon as it's ready. So next, we're going to talk about the quality measures and why they're important. So the first measure is HEDIS, which stands for Healthcare Effectiveness Data and Information Set. And HEDIS measures are used by more than 90% of health plans in the US. And the information is gathered is used to improve care and services provided to enrollees. HEDIS measures provide transparency in comparing data between the health plans. And currently, the data collection and analysis is led by the Office of Healthcare Statistics, which is within our department. The next measure is CAPS, which stands for Consumer Assessment of Healthcare Providers and Systems. CAPS measures are performed by a third party to measure perceptions of care. A questionnaire is sent out to enrollees, asking them about their personal experience with the health plan and the services that they receive. And the health plans use these services to identify strengths and weaknesses in the service delivery. CAPS provides consumers valuable insights that can assist them when they are selecting a health plan. Utah health plans are required to submit HEDIS and CAPS service data, or service results, excuse me, to promote informed consumer choice and plan selection and measure quality of care provided to enrollees. And those are listed in the rule that's listed here. And currently the HEDIS and CAPS survey results can be found at the website listed. Excuse me. Okay, next slide, Greg. Okay, HEDIS and CAPS quality measures are tracked by the Office of Managed Healthcare for adult Medicaid, child Medicaid, CHIP, UMIC plans, and PMHPs. And the data we're about to go through covers the reporting year of 2024, which is reflective of the calendar year 2023. As I mentioned, the data collection is done by OHCS, and it's currently a collaborative effort between their office and the Office of Managed Healthcare. Annual HEDIS data and audit reports are submitted by the plans to OHCS. OHC manages the collection of CAP surveys through the state's preferred vendor. And then OHCS posts the health plan HEDIS and CAPS data at the stats.health.utah.gov website as listed. And in the future, we'll be working with our newly developed Utah Population Health Management System for this data, which Greg actually talked a little bit about that earlier. So, and as I mentioned, we provided a report for your review that includes many more measures, and we'll send you an updated draft. But in this presentation, we're just going to focus on a few of those measures. Also, I'll just mention real quickly that in January, the plans will be attending the MAC meeting to provide more detailed information on their plan performance. So on this slide, the first measure is the W30, well child visits in the first 15 months. You'll notice that we have seen an improvement at the plan level over the past 3 years. However, the state average has fallen below the national average for most plans over the past 3 years. And as Greg mentioned earlier, the collaborative ACO PIP chose this measure as their topic in 2023 and produced that well child visit tracking card to help with this measure. So next slide. This measure is the well child visits 15 to 30 months. And during the 2024 reporting year, we did get closer to meeting the national average overall. This measure counts the well child visits with a PCP during the last 15 months. And it also includes children who turned 30 months during the measurement year and had 2 or more well child visits. And just to mention, this W30 measure replaced the W15 and W34 measures beginning with the 2021 reporting year. So next slide. This measure is the Childhood Immunization Combo number 3, or CIS. And we have seen some significant improvements that were made for this year for this measure. And we were very close to meeting national averages with all the plans. One thing that we plan to work on in the future with the plans is just to find out a little bit more about any challenges or obstacles that may be contributing to the measurements. So that's that slide. The next slide is immunizations for adolescents, combo number 2, or IMA. All the plans did experience a decrease on this measure. So again, like the last one, we do plan to work with the plans in the future to identify any challenges or obstacles that they may be encountering with adolescent immunizations. So those are just a few of the measures that we have identified here. You'll find in that larger report many more of the measures. And like I said, we'll send that updated draft out shortly. So with that, that's the end of our presentation on managed care quality. So does anyone have any questions for us?
Yeah, and I just wanted to close out and just say that we were just highlighting these measures because these were some specific things that we had focused on, both from our quality incentive pool to our quality withhold program this year, through our collective PIP. These are some key things that we were trying to just drive out improvements in. And so that's why we were highlighting these in particular.
You might have said this, Jennifer, and I think I have asked this in the past, so sorry that I forget, but that national average, is that like the national average for like Medicaid members, or is that national average just like of all children?
I think, Greg, that's, I don't
No,
want to answer the wrong answer. Is it all or just Medicaid? I can't recall, sorry.
It's Medicaid. All
It's just
Medicaid.
Okay, thank you, Rachel.
Okay, I thought so, but just wanted to make sure. Thank you. And thanks for that information.
Did someone else raise their hand?
Lynette, did you have anything to add, or was that a mistake?
No, I was just going to say, if you're using the NCQA benchmarks, they do have separate benchmarks for Medicaid.
Okay, yeah.
Okay.
Okay, well,
thank you for your time. We appreciate having the opportunity to come and share. As Jen mentioned, we'll send out an updated MAC report, which was the document with all the various measures on it. And again, as Jen noted, it sounded like the intention is for the January MAC meeting to include an opportunity for the ACOs to come and talk about individual plan performance. So look forward to that as well. Thank you all for your time.
thank you.
Thank you so much, Greg and Jennifer. We appreciate it. Yeah, I believe that's true. That there'll be an opportunity in January to talk to the plans. And then we'll have a little more time to look over the report as well. So once that's done, I would encourage members to look at that before the January meeting. So with that, I think we can move on to an eligibility.
Hey, Rachel, can I?
Yeah.
I did want to just ask for that, for the January meeting. I know last year one of the things that I know I had asked for, and I can't remember if others said this would be helpful too, would be like if there was like standard things we were asking for the plans to present. I don't know if that's something that is possible, or just like, I remember it just being like, not all the plans, had the same kind of presentation and had the same kind of information. So it was just kind of hard to compare. So I don't know if that's something that you all are like working with them on, or if that's something that we can discuss, or if we have input that we can email to anyone. I just wanted to bring that up again since we talked about it last year.
So this might be a question for Jennifer Strohacker or Sharon. Is that something that executive committee could put together? So Steph,
Yes.
I'll commit to putting something together. I'll go through the report, and then maybe pick out some areas that I think, show a lot of like, I don't know, differences, or something that just looks like very low or very high, to have them talk about. Maybe that's a good idea. And then any MAC members, if you have any suggestions of areas and interests specifically that you'd like the plans to talk about, please send them over to me and the rest of the executive committee, as well as Sharon and Jen Strohacker. And we'll put something together so there is some standardization. Steph, I think that's a really good idea. Anything else, I guess, and right now, any other MAC members, do you have anything off the top of your head that you'd like to see reported on, specifically in relation? I know the report's going to be resent out, but if you did have a chance to look at it, anything else that you can think of right now? Because I've got a notepad, so. Okay, and then I have a request, and I don't know who this is going to go to. When we redo the report, is there any way that we can put percentages on the bar graphs? Because I have a really hard time reading bar graphs without like actual percentages. So if you could like print those on there, I would be so thankful. Thank you.
we can do that, Rachel.
Thank you so much. I appreciate
Sure.
it. Hey, yeah. Anyway, with that, if there's nothing else, eligibility enrollment update is up next from Michelle Smith.
Yeah. Hi, Rachel. Thank you. Hi, everyone. I am going to go ahead and present. I'll be going through the enrollment dashboard as well as the outcomes dashboard that we have online. So let me drop this in the chat, as I always do, for anyone in the meeting who may not be familiar with where to find the enrollment data, but I'll just quickly go through this. So for November 2024, our current total member count is 340,502 individuals. So you can see past few months, we've stayed pretty steady. If you go to the more detail on the data tab above, there really isn't anything to note in terms of significant change between each of the Medicaid categories. They're all pretty steady, no significant drop or increase in any of the programs. So again, hopefully you guys are able to access the link that I dropped in there. Okay, and look through this in more detail if you would like. But those are the two that I'd like to focus on, and there's really nothing significant to note. So I will, before I kind of pause, I'll just quickly move over to our data eligibility dashboard. And I'll just focus on this first tab on the review outcomes. So again, we report monthly still to CMS our review outcomes, and I'll drop this link in the chat as well so everyone has that. So this report gets updated monthly. And as you can see, we're still doing really well with our ex parte. We're at almost 41% automated and manual ex parte. So we're really making some progress. Again, that just helps ensure, eligible individuals to stay covered onto the programs, which is great, and reduce that overall procedural termination that we've been working on. So that's really good to see. Again, at the top, there's other tabs that you're welcome to look at and kind of see what those outcomes are on a monthly basis. But like I said, I'll just focus on this tab. And that's really all that I have to show. So I'll just stop there and ask if there's any questions. Oh, I think you're on mute, Rachel. Sorry.
I pressed it twice. Thank you. If there's no questions, then I thank you, Michelle. We appreciate your report as always. Then I think we can move on to the new enrollment dashboard. So Michael Keith is up next, and you can take it away.
All right. So we have a new dashboard that Medicaid has developed, and we've shared with our leadership. They think it's interesting enough to post to our website. Wanted me to present it to the MAC to get any feedback. We haven't posted this one yet, but we. I don't know. I'll work with Michelle to see about that as far as a timeline. But this is just an additional detail eligibility, and really the genesis of this is we frequently receive grandma requests for this level of data that we're having to fulfill over and over. And so our hope, like in Medicaid, is to be able to provide that data publicly and have a one-stop shop for people to go who need this data or are interested in it. But it shows enrollment broken down by dual eligible and non-dual eligible and by health district. So some of the smaller counties are combined into health districts to just protect PHE. And sorry, to protect PHI. Personal health information. The fear is if there's just a few members in a single county, then that might cross into that boundary of being identifiable. But so yeah, it's interactive. You can click through the different health counties that you're interested in, see the trend over the last 2 years broken down monthly. You can unclick dual eligibles or vice versa to just see trends of one and not the other. So it's pretty helpful that way. This tab shows the same enrollment data, but instead of broken down by health district, broken down by managed care plan. So you can see our fee-for-service population, Health Choice Utah integrated. You'll notice there's no dual eligibles in this plan, and that makes sense. Health Choice Utah Inc. and et cetera. All the health plans are there, including CHIP. And you see CHIP has kind of that opposite trend as Medicaid. And then moving on, this shows enrollment trends by health district. So you can see kind of the trend by health district altogether, right? To see relative differences in the populations. And this is the same thing by health plan, by those managed care health plans. And finally, the last tab that we have are these pie charts to show kind of this distributions broken down by month. So it defaults to the most recent month available. And you can go back several months and just see kind of 1 month snapshots and how our eligibility is distributed both by health district and by health plan. So yeah, I can answer any questions or review anything else that anyone's interested in related to this. Stephanie, I'm glad to see your comment because this was a lot of good work by members of my team. So thank you for that feedback.
Can you put the link to that, or is it not live yet? Sorry if I missed that part.
Yeah, it's not on our website yet.
Okay, cool. Yeah, this is just exciting. Thank you.
Yeah,
And
this
Stephanie,
is really cool.
When it does get placed on the website, I think our goal is to have it right by our current enrollment data dashboard, so that it's easy to just navigate between them. And so, yeah, so as soon as we do get this posted, we'll obviously let you all know, but we're going to keep them close to each other so that it's easy to go from one to the other.
Great. Any other questions for Michael? All right, Michael, thank you so much. This is exciting. I love this personally.
Yes, thank you.
I always love more enrollment. I like when I don't have to bug anyone that works at Medicaid for more data and then it's just there. But I know there's a lot of work behind putting it together. So I think I speak for everyone when I say that we really appreciate it. All right. Next up is Director Jennifer Strohecker with the director's report.
Yeah, good afternoon, everyone. Just a few updates we want to share with you. A couple things. I don't think we've brought this to this committee yet, but we're really excited about some work that's being done with CMS regarding our 1115 waiver requests. We have been selected to receive an expedited review from CMS on 2 of our items, and I don't think I shared this last meeting, so we're excited to bring this to you now. The first waiver that is under an expedited review is our adult dental waiver. And that adult dental waiver, we should receive approval from that. If all things pan out with CMS, we're expecting approval for that waiver on January 13th. And our goal is to go live with that program on April 1st. The second item that we'd like to share is our housing waiver request. The housing waiver has been bundled into a new type of waiver called health-related social needs. And within that specific waiver, it does contain 3 different elements of different types of housing supports that incorporate room and board. And this waiver also is under an expedited review with CMS. And we do anticipate approval for this waiver on January 13th as well. And so let me just give you a little bit of detail. We are still actively working with CMS on what all these components are. We will put them together in a more comprehensive presentation for you when we finalize those details, but wanted to share at a high level what those 3 housing components are. So The first, as we have shared, is medical respite. This is an older request that went through the legislature, I believe, in 2021, maybe 2022. And we've been kind of working with CMS on this request, but it's got stalled because there is an overnight room and board component. And so with the approval of this waiver, we're really excited about medical respite services. This service specifically is for individuals who have housing instability or at risk or are homeless and are being discharged from an inpatient setting or a nursing care facility. The individuals who meet this criteria have to have a home health level of care. So they have different eligibility components, which of course we'll bring to you when we have a more final package approved. But essentially, this would allow up to 60 days of medical respite service per calendar year for individuals. They don't have to be consecutive 60 days, but a total sum of 60 days of this medical respite component. Individuals who would be served under this waiver would be adult expansion or our TAM population. We are going to, once we have approval of this, we will solicit an RFP for 2 different facilities to be able to provide this service. Our RFP, we hope to have posted shortly after approval. We will begin that process of getting that through our purchasing and then posted. And if all times out properly, we would love to have this policy in place by July 1 of 2025. The next item that is within our HRSN waiver is, go ahead, Rachel.
This is an easy question. Did you say the medical respite one? Do you have a date for or expected date for that one, or is that part of January 13th?
It's part of our January 13th approval with a go live date of July 1 is our hope.
Cool.
Okay.
Thank you. That's helpful.
Yeah. And then the second piece that we're looking at is the HRSS request, which is housing related services and supports. This actually takes our existing HRSS benefit, further defines it underneath our new HRSN waiver. So there will be some slight changes to what we have today, but it actually expands this. Today we serve our TAM population under HRSS. We will be expanding this to our justice involved population. Any individual above 18 years of age and older, and those who've been justice involved within 12 months. It also provides this benefit to adult expansion members as well. And the housing related services and supports, that one is hopefully going to go live on July 1st also of 2026. The third element, go ahead, Stephanie.
Yeah, I'm just curious. Do they allow for like any, like for adolescents? I mean, I hear that you say 18 and above, but just curious, are any states doing it for like adolescents that are justice involved?
I don't know if any state is or not. We could ask. I'm uncertain about that. If that would include adolescents or if the parent would qualify. And so it would give the children the opportunity. But I don't believe that as an adolescent alone, that that I'm not aware of any states that have adolescents alone.
Okay, thanks, Jen. Sorry.
Yeah. No, it's a good question. And we can ask CMS. We meet with them regularly on these, and we can ask about current approvals and if there is any state that does that. Last but not least, within this health-related social needs package is our rental assistance. Oh, let me go back to HRSS. HRSS can be packaged along with rental assistance. So we believe individuals could actually be served through both. Okay. So you could have HRSS because those are wraparound services that help the individual with navigating and paying for lots of months rent and different like housing supplies, as well as utilities and care management, case management, that would be part of that. So that HRSS package could actually be bundled together with rental assistance, which is the third part of this waiver. So rental assistance would also be approved if all goes as planned by January 13th, and rental assistance allows up to 6 months of rent to be covered for a Medicaid enrolled individual who meets the same criteria of housing instability that we're using for HRSS. So we're applying the same definition for an individual to meet both the housing HRSS benefit as well as our rental assistance benefit, is what our proposal with CMS is. The rules underneath CMS are that we are allowed to pay for 6 months of rent every 5 years. And so I just wanted to state that. Of course, we'll say it multiple times as this package gets approved and we go live with the benefit. We'll make sure we say that this 6 months of rent does have limitations, that it is 6 months of rent for every 5 years. Go ahead, Andrew. Oh, I'm so sorry. Okay, there you go.
Sorry, Jen. I was thinking I was going to be on top of it, and then of course it all fell apart. Just a quick question: that's great news about the rental assistance piece. I don't know if I saw it, but if you could remind me, does that include help with first and last and application fees and things like that as well?
Yeah, that component, good question, Andrew. That component, yes, would be included in HRSS. So the existing housing related services and supports that we already have that would be available could be added on to rental assistance. So you could use the funds from, I guess that's part of the package. I guess one thing to be clear on, rent, even if it's HRSS and the benefit of HRSS plus rent, we are not allowed to exceed more than 6 months duration period. So you could get first and last month's rent covered under one, but the 6 months of rent does cover that anyway, right?
Okay.
So a person could get just HRSS, they may just get 6 months of rent, or they may get both.
And of course, I'm assuming that deposits would be contemplated in there as well.
It would be. Mm-hmm.
Okay, great.
Yep.
That's
good question.
That's great. Thank you so much for that. I appreciate it.
You're welcome. Just to share with the MAC that the 6 months of rent and the rental assistance portion of this, we don't have a timeline for when we will be able to implement this following our approval in January, because it is a little bit of a different policy. We need a little bit of extra time to work through it. But as we meet with other states and learn more about it, we'll provide updates here with regard to when we could go live with that benefit. So we're excited about that and are grateful that CMS was able to expedite the review of those two waivers. All right. Next item I would just like to share with you quickly is just a milestone that we were able to accomplish with regard to some of our reporting requirements to CMS around eligibility renewals. So in the fall of this year, on September 20th, I can pivot back, Jeannie, on your question. We don't have final documents yet, which is why I'm not displaying, because we're still actively negotiating the details with CMS. But as soon as we have a final approval package, we will be making those documents publicly available. Yep. Good questions. Thank you. Okay, so let me move quickly just to I'd like to just update the MAC on a submission that's happening this week. In the fall, on September 20th, CMS did release an informational bulletin that actually released a whole, oh my gosh, it was a comprehensive request of eligibility data from states regarding their renewal processes. The request from, and I can actually include here the informational bulletins link. Sorry, I'm trying to hear, so you can take a quick look at it. But following unwinding and kind of some of the lessons learned through unwinding, it was of interest to CMS to create greater transparency awareness around what states were doing broadly around their eligibility renewal processes. And as a result, in this informational bulletin, states were required to submit a number of documents with really comprehensive eligibility data on it by the end of the year. This includes numerous things, including information around ex parte renewals, renewal forms, a timeline to return the renewal forms, the state's process to submit renewal form through all modalities, the reconsideration periods at renewals, including other things too. So through each of these assessments, between the Department of Workforce Services and our Medicaid eligibility team, we had to go through and assess each area as being within compliance or being out of compliance with each of these areas. And I'm wanting to report to the MAC that among these 9 key areas for states, Utah was fully compliant with 6 out of 9 of these areas. There was one area that one of those 3 outstanding areas, we will be fully compliant with this by January 1st. And then on the 2 areas where we were partially compliant, we will be coming into compliance within the early part of 2025. I wanted to just highlight at a very high level this body of work that has been completed. We have more than 100 pages of documents that are being submitted to CMS on behalf of Utah to fulfill these reporting requirements by December 31st. And that exercise is completed. I'll be actually sending it off to CMS tomorrow. The team really literally just finished this work this week, and we were able to go through and review the outcomes with that. It was too early to be able to present it in this meeting. But if there's interest at the advisory committee level, executive level, and Rachel and others would like to have us bring a little bit more data on what are these elements, how did Utah do, when can you be in compliance, we'd be happy to do that in future meetings. I just wanted to share with you the work that had been done. And we're actually quite pleased at the enormous effort that was put in by the teams to get this done. We can bring more to a future meeting. Okay, thank you for that. Last, wanted to update quickly some efforts that have been made to promote access to cell and gene therapies that are coming to the market. So I'm switching to pharmacy quickly and talking about novel medications that are often, we've termed them ultra high cost drugs. These are drugs that are more than $1 million for one dose. Technically, they are known as cell and gene therapies because they can often go in with this one dose, be administered to a patient and alter the way the body actually may see a disease and may change the genes or other factors that happen inside the cell to actually remediate the disease and actually may even be curative in nature. We've talked a lot about these over the last few years. As we know these drugs and more of this pipeline is very rich. And it's a key area where really Medicaid members who may be living with rare diseases or really expensive chronic conditions that Medicaid members experience this. And we've been working diligently to really promote and be able to manage, promote access to, but also financially manage these drugs. One of the aspects I would say from a pharmacy perspective is that because of Medicaid's rules around being able to promote access to medications for Medicaid members who may be, high-risk populations and also have other, challenges in a disproportionate way compared to other populations. If a manufacturer participates in the Medicaid drug rebate program, Medicaid has to cover that drug, okay? So just by the rules of how Medicaid pharmacy works, when these drugs come to market and are available, and let's talk about sickle cell drugs, for example, if the manufacturer, there are 2 sickle cell drugs that are coming to market, and if the drug manufacturer participates in the Medicaid drug rebate program, automatically the Medicaid program must cover these products. So I just want to state that so that you're aware, as you may see the news and hear media saying novel treatments available, it can be curative, and these certainly are game changers for people who have lived with chronic disease. I want you to know that, first of all, Medicaid will be covering these products as long as they meet those rules. And so one of the opportunities that we have as a state as we consider what these drugs look like, and we know that more and more will be coming to market. If I were to give a specific presentation on the cell and gene therapy pipeline, we know that by 2025, 10 to 20 of these drugs will be released to the market per year, okay? And I already mentioned that they're high cost, but they can also be complex in how they're administered. And they're also very expensive. And so one of the opportunities we have as a state, in order to really understand how to build the best system of care for these drugs and the people who receive them and all of the folks, stakeholders who may be managing the care of these individuals, is to be involved in what's called the Cell and Gene Therapy Access Model. This is a model of care established by CMS, and states are able to apply to it. And we can actually, there's a design of this model that really looks at all of these components. It, of course, is aimed to be person-centered, but looks at, our managed care entities, the state Medicaid program, providers, community-based organizations, the patient voice, right? All of these different components, and it helps us build a framework by how we can build a good model so that when a person is eligible for one of these products, they may actually find that right pathway to be successful, not just to get the one-time drug infused, but there's a lot of care coordination that's involved around that. One important thing I think just to appreciate with the MAC is that sickle cell treatment alone is about 6 months of care that is necessary for a person to first be identified and then go through different treatment steps up until that true cell and gene therapy can actually be administered, that drug. And so it's important, even this one is kind of a longer duration of treatment, that person is able to be successful through all those different steps up until the time they get their drug. So bottom line is Utah is applying to this cell and gene therapy model. It builds a model of care, but also there are value-based agreements around the cost. So CMS is actually negotiating with these manufacturers who make these drugs, specifically sickle cell, and is able to negotiate on behalf of states value-based agreements to ensure that when the state pays $3.2 million for a treatment, that there are guarantees around a person being able to truly receive and achieve the success of that treatment. And then if the person doesn't meet certain milestones and the drug isn't working, you get some of that money back. So wanted to share that in the context that we are actively drafting the grant. The deadline to submit the grant, it's an open deadline. We could submit now, but we won't be ready to submit until about February. And then we would like to be able to participate, hopefully be considered and be selected to participate in this model. So I wanted to just share that with the MAC, and I'll take any questions with you that you may have, and I can bring more information as we have more in the future if interested. Okay, last but not least, since it is the end of the year and we have something important happening right around January 1st that I wanted to share just as with regard to an important milestone that we've been working on with regard to incarcerated youth. You are familiar with our justice waiver, that there is a component of our justice waiver and a piece that came out of the Consolidated Appropriations Act around juvenile justice and requirements for states to identify youth who were in a juvenile justice setting and determine Medicaid eligibility 30 days prior to release, and then provide care coordination and targeted case management within that 30-day window. And then that targeted case manager will follow the individual into the community, and they are meant to follow them for at least 30 days. This is sort of the lower level basic plan. Utah has the opportunity to expand our juvenile justice to match the full adult waiver in the future, and we do intend to do that. But what I wanted to share with you is that we are going to undergo a soft go live of our juvenile justice work. We've been working very closely with our juvenile justice partners to look at eligibility screening at that point of entry. We've been working with their medical staff that are enrolled at, that work at these juvenile justice settings, and they're getting enrolled as Medicaid providers. We are developing and working with them to align with a care plan that looks like the adult care plan that we will use, and they are matching their electronic health record components so that a youth care plan will look much like, so that the youth care plan and the adult care plan have all those components around physical health, behavioral health, substance use, so that social determinants even. So as the youth transitions to the community, these components can be handed off to community providers and to the managed care plans that are taking care of these youth. We're also working with the care managers that work inside of JJYS right now. We needed to first get them certified as care managers as part of our certification process, and they have all been certified. This is a big milestone. There's more than 100 of these individuals who became certified, and they are now enrolling as Medicaid providers. And then what we hope to do next as we further this program is to build out our resource documents. So we're working on Medicaid 101 trainings that will work to help educate individuals who are working and serving inside the carceral setting. We're going to design them right now with JJYS in mind, but we are going to use them in our adult settings as well. And our goal is to make them transferable to the adult setting as well, so that we have similar Medicaid 101 trainings. And these are all like, who enrolls in Medicaid, who becomes eligible, what does that look like here in Utah? Looking at like what sorts of services get covered under the Medicaid benefit? What are the managed care plans? What does it mean if I say that I am a Healthy U enrollee, or I'm a PMHP enrollee or something, and really helping them figure out and understand these components so they can successfully navigate, and we'll teach them eligibility and all these other things. So you can see we're building and using this soft go live with JJYS, which of course is within the Department of Health, as a real environment for us to establish a good process. I'll tell you, we will fully go live after the May PRISM release. Our MMI, our Medicaid billing system, PRISM, will have the justice benefit programmed in it in May. And so we will kind of do this soft go live work around juvenile justice up until May, when our systems, our eligibility systems, and both our billing systems are activated. And at this point, we will go full live. But I wanted to share with you this exciting news that we really are, I would say, a leader in our state, among the states, in being able to really lay down a good foundation and a pathway to be able to envision how this works. We aren't truly doing the work yet from a systems perspective, because we don't have our systems in place, but we are actively training and building all of the operational documents, and we will be ready to go live in May. So with that, I'll take some questions, and thank you for all your comments so far. Go ahead, Brian.
Hey, thanks, Jen. And I really appreciate the work on this. This is a really great thing. Are you working with all youth facilities throughout the state, or is this like just Sully County, or at this point, or it's all facilities in the state?
Yep, it's all 6 facilities. There are, I believe, are 6 secure care facilities. These are the youth. We chose those that are in secure care. This won't be youth in like residential or other at this point. We may expand in the future as as we figure out how this can work successfully. We may think about it, but there are some important linkages as we think about gaps that people fall into, and we've been in active conversations as a person's in JJYS custody, and then they move to DCSF, and then they move back into the community and are enrolled. And all these are places where people have, really struggled, and maybe our programs have struggled. And then consequently, the youth and the individual being served and the families that maybe are working with them also struggle. And so I think we want to carefully map this out over the next few months and really thoughtfully consider those handoffs as they occur today. And I know I went a little bit further, Brian, but I wanted to say we're starting smaller, but they are about 200 youth in secure care. And I'll just say our vision for this is getting upstream. Our goal is to connect youth in this way in our state who may enter the adult system and then be stuck in the adult system. And if we can really do these services effectively and wraparound care properly, it is possible we could really engage youth in proper behavioral health, physical health treatments, and substance use treatments, and really give them those, address their needs earlier. And our goal is bend the curve on this. So anyway, thanks for the comments and thanks for the question.
I appreciate it.
Yeah.
I work with like 30 of these youth and their families about 3 nights a week. So if there are things that I can do to help move things along, I'm happy to do it. So
that's great, Brian. And
Thanks.
if you, as we roll this out officially, we'd always love, your input if you're finding ways that we could do it a bit better. I will say that I know there's some managed care individuals on this call that we're kicking off sort of that external handoff to the community and making sure that arrangement, we've kind of been trying to get all of our internal work figured out within the department on this matter. But in January, we're going to be kicking off work with our community. We'd love to start thinking about the community based organizations, our managed care entities, and all of those as we think outside the facility. Right now, we've been pretty focused on inside the facility, but we're going to start thinking about outside the facility early next year. Okay, that's it. Thanks for an opportunity to provide some updates on this.
Did anyone have any? Oh, Steph, go ahead.
Yeah, that was all really great, Jen. I have a kind of weird question that I just want to be able to understand. That's kind of like a part of these things, but also separate. If there was a scenario where federal policy changed Medicaid to be block granted or per capita, whatever, and there was a huge reduction in the FMAP, I'm just curious, I know people maybe don't want to talk about, I'm not saying we should talk about it. I'm just are you guys discussing those things, or what, as an advocate that is being asked all the time by Medicaid members, what's going to happen to them? I know that we don't know, but I'm just trying to understand, from y'all's perspective, there does seem to be some similarities, at least in my understanding, between the bill that was proposed and was defeated at the legislative level and some of the federal discussions, some of the federal plans, just in the sense of what it would do to jeopardize federal funding into the state and just cutting the budget. Some of these efforts that you all are working on, would those be impacted by especially with the waiver stuff and just some of these more it's I guess some of that would be seen as optional services, and so in a situation where Medicaid funding was reduced 50%, would that I mean, those things wouldn't have funding, right? Or I just trying to like wrap my mind around how you all are seeing this, if you're able to share. And
Yeah,
I'm
thank
sorry
you,
for an
Stephanie.
uncomfortable question.
Yeah, I think I'll just tell you there's a number of scenarios that could happen, right? And I'll just say at the national level, and I serve on some committees for NAMD, and we talk about like the policy. I'm on the policy committee, and there's a lot of dialogue around what could happen. But right now, I don't think there's enormous concern about or fear being circulated around it for states, like around adult expansion. If the FMAP were to go down, we are that would take an enormous effort. We don't see any proposed bills. We know that it obviously needs to take enormous effort on the congressional side. The voter base for the incoming president, maybe a lot of Medicaid eligible individuals is what we've discussed, as well as representatives and on the federal side, lawmakers who may lose their voter base if certain things happen. And so I think it's been pretty conservative with regard to worrying about what could happen, right? And even like within our own state, I would just say we've discussed dusting off and looking at, certain types of things like work requirements and looking at what that might look like again. And certainly, I don't want to say dusting off, but, just bringing that back to our memories, right? Because it will come up, and we have been asked questions about this already. Utah has a trigger law around its adult expansion program. What happens if that FMAP does change? But right now, like we don't have any signals that would indicate that we need to be too concerned about that right now, I just say. And so as a result, we're moving forward. We believe in these programs that are critical to our adult expansion population and to keeping them healthy and helping them, really receive the healthcare services that they need in the settings where they are. And so we're moving forward with the work. So we don't spend a lot of time concerned about what's happening at the federal level because we don't have indicators from the federal level that things are moving in that direction right now. I hope that's a roundabout but okay response for you.
Yeah, thank you. Do members of Congress, like, do members of Congress meet with you all or ask you all for like input if there was if they were discussing something? Do they ask you how it would impact the department, or is that, I know you talked to the legislature, so I'm just curious if you all are also consulted with by members of Congress.
I personally have not met with any members of Congress on these types of topics. We've certainly provided some materials to our governor's office on things, but I've not personally met with any members of Congress, nor am I aware that Tracy has either.
Okay. Thanks, Jen.
You're welcome.
Anything else for Jen before we let her go? Okay. Assuming no, then this is just time for any committee member updates. So I'll just pause for a second, see if there's anything that anyone wants to share or any last minute questions they want to ask while we're here. I'm muted again. Sorry about that. I'm doing a bad job of that today. Okay, assuming we don't have anything else from any other committee members, our next meeting is January 16th from 2 to 4 p.m. On Zoom. Please take note that we are going to start moving on to, and I don't have it in front of me right now, but Sharon did send it out. Our meeting schedule is going to change and we won't meet every month now. Starting in January. So we'll have January, and then I believe our next meeting after that is March. So just take note of that. Change your calendar invites accordingly. But I think we are all done here today. Everyone have a happy holidays. Travel safe if you're traveling. Be safe wherever you are. Appreciate you all and have a good afternoon.
Thank you.
Thank you.
Thank you and happy holidays.